Yes, good afternoon, everybody. My name is Peter Steensma. I'm the Clinical Strategy Director for Women's Healthcare Ultrasound, so the Voluson. I'm very happy that you are joining now this lunch symposium with the Advanced Insights in Fetal Brain, Third Trimester, and Gynecologic Ultrasound. We have fantastic speakers, but first I would like to introduce the moderator. I think very well known by everybody of you, so Dr. Nicola Persico. Very well known in the prenatal diagnostic and intervention. So thank you, Nicola, and I would like to hand over to you.
Thank you very much, Peter. Benvenuti a questa sessione. Ringraziamo la GE per averla organizzata e soprattutto per avere a disposizione degli speaker di rilievo internazionale. Direi che una parola, giusto per introdurre e non rubare tempo alle relazioni, una parola va spesa sullo spessore scientifico di questo congresso, sia dal punto di vista dei contenuti che dal punto di vista della presenza di relatori di un certo peso, sia a livello nazionale che a livello internazionale. E questo poi appunto si riflette anche in questa sessione che vede un po' cercherà di coprire lo stato dell'arte per quel che riguarda l'ecografia sia in ambito ginecologico e oncologico, sia per quanto riguarda la parte ostetrica con l'ecografia del terzo trimestre e la neurosonografia. Poi introdurremo via via i vari relatori. Speriamo di avere qualche minuto alla fine per delle domande, un po' di discussione. Non perdo altro tempo, introduco la prima relatrice che anche voi conoscete tutti, che è la dottoressa Valentina Chiappa, con un'esperienza ormai consolidata anche in ambito internazionale nell'ambito dell'ecografia ginecologica e che lavora presso l'Istituto Nazionale dei Tumori di Milano, per cui ci parlerà del ruolo dell'ecografia nella ginecologia oncologica. Prego.
Buongiorno a tutti, grazie Nicola per la presentazione. Mi unisco ai ringraziamenti a GE e agli organizzatori del congresso per questo gradito invito. Oggi vi porto nel mio mondo, nel mio ambulatorio, e voglio darvi un'idea di quello che è il ruolo dell'ecografia, la potenza dell'ecografia ginecologica nello studio della patologia della pelvi femminile. Andremo a vedere una carrellata di quello che può capitarci quotidianamente e come lo gestiamo in tutte queste condizioni. Partiamo dalle masse annessiali. L'ecografia ginecologica accompagna il clinico nella valutazione e gestione della massa annessiale dalla diagnosi alla definizione di quello che è il trattamento una volta effettuato il triage della massa, fino al follow-up e la possibilità di fare una diagnosi rapida mini-invasiva in caso di sospetto di recidiva nelle neoplasie annessiali. Iniziamo da quella che è la diagnosi e il triage delle masse annessiali. Noi sappiamo che ci sono delle caratteristiche delle nostre formazioni annessiali che dobbiamo assolutamente conoscere, in particolare se c'è componente solida, se ci sono papille quante, la vascolarizzazione, se ci sono coni d'ombra, e questo è importante perché direttamente implementati nella nostra macchina ecografica abbiamo degli strumenti di supporto decisionale che possono aiutarci a confermare o a sollevare dei dubbi su quello che stiamo vedendo. Ma iniziamo subito con dei casi clinici. Vi faccio vedere questo caso, è una formazione uniloculare solida, riconosciamo la presenza di 2 papille, il contenuto è low level e dobbiamo effettuare un triage efficace di questa formazione. Possiamo ovviamente utilizzare i software 3D e ottenere una ricostruzione più accurata di quello che è l'interno, il profilo interno irregolare della nostra lesione, e proviamo già a fare diagnosi. Vediamo, abbiamo le simple rules direttamente nella nostra macchina che però in questo caso non sono applicabili. Allora utilizziamo ADNEX, andiamo a inserire tutti quelli che sono i predittori clinici ed ecografici e otteniamo il rischio specifico della nostra paziente. In questo caso un rischio intermedio, un rischio superiore al 10%, che ci suggerisce di centralizzare la paziente se non siamo parte di un centro oncologico di riferimento. Se vogliamo anche un suggerimento per il management della lesione, abbiamo anche uno strumento diverso. Direttamente nella macchina abbiamo il sistema di classificazione ORADS, sviluppato in collaborazione con l'American College of Radiology, che oltre a identificare una classe di rischio della massa ci dà un suggerimento per il management, e così molto semplicemente andiamo a definire che si tratta di una lesione ovarica non di quelle che in genere riconosciamo con gli easy descriptors, che ha componente cistica e solida, meno di 4 papille, un loculo solo, no ascite e non formazioni peritoneali, e è una classe ORADS 4. Che cosa vuol dire? Vuol dire, se non sei un esperto, centralizza la paziente, o in alternativa, se non hai una rete di centri di riferimento, richiedi una risonanza magnetica. In questo caso era una formazione comunque benigna perché era un cistoadenofibroma atipico. Vediamo un altro caso, una formazione sempre uniloculare solida, contenuto anecogeno, con una papilla in cui riconosciamo questo pattern un po' microcistico, papilla vascolarizzata, con vascolarizzazione che riusciamo a cogliere ancora meglio con la ricostruzione con il 3D Power Doppler, e ancora andiamo ad applicare quelli che sono i nostri modelli. Simple rules non applicabili, anche in questo caso, andiamo con ADNEX. Andiamo a inserire tutti i nostri parametri, rischio di malignità molto simile al precedente, un rischio di malignità del 32%, con un rischio relativo maggiore per la sottoclasse di maligno borderline. Ancora possiamo utilizzare ORADS e andare a vedere che cosa ci viene suggerito per il management della paziente. Andiamo a inserire tutte le feature che ci vengono richieste, ci vuole veramente 10 secondi. E ancora classe 4, centralizza la paziente, se non hai modo richiedi una risonanza magnetica, ma siamo a un congresso di ecografia di una società scientifica nazionale, quindi l'obiettivo è avere modo di avere una rete di ecografisti di riferimento. In questo caso si trattava di un tumore sieroso borderline. Con l'ecografia andiamo oltre, non facciamo solo il triage della lesione benigno e maligno e la portiamo in sala operatoria. Oggi utilizziamo l'ecografia anche per andare a stadiare e predire la citoriducibilità della nostra paziente, del nostro tumore. In questo caso vi faccio vedere, per motivi di tempo, una formazione sospetta per tumore invasivo con un macronodulo di carcinosi pelvica. Vediamo molto bene, ve lo faccio vedere, no, il nodulo pelvico là nello scavo del Douglas che infiltra il retto sigma almeno fino allo strato muscolare. Possiamo seguire meglio il retto partendo proprio dall'ano, andiamo a srotolare il nostro retto sigma finché arriviamo a incontrare il nodulo pelvico, e andiamo a studiare molto bene quelli che sono gli strati del retto sigma per definire lo strato più profondo interessato e quindi lanciare un alert al chirurgo sulla necessità di prevedere una resezione intestinale che allunga i tempi operatori, richiede ulteriori specialisti. Con i rendering 3D possiamo andare a studiare molto bene quella che è la superficie interna della nostra lesione, ad apprezzarne il profilo interno, le mammellonature, e questo era il corrispettivo macroscopico. Per quanto riguarda invece la patologia endometriale, il ruolo dell'ecografia in primis è quello di andare a descrivere il nostro endometrio e a identificare quelle lesioni che sono meritevoli di una diagnostica invasiva, perché oggi non è più accettabile concludere un'ecografia banalmente con la misura dello spessore endometriale, perché sappiamo che un quadro come questo, in cui riconosciamo un endometrio disomogeneo per la presenza di una formazione iperecogeno ovalare del layer posteriore con un bright edge iperecogeno e un pattern vascolare di singolo vaso a origine unifocale, già così è diagnostica per polipo endometriale, che poi possiamo andare a enfatizzare meglio con i rendering tridimensionali che la macchina ci offre, e che è un quadro estremamente diverso da questo, in cui abbiamo comunque un endometrio disomogeneo per la presenza, perché abbiamo una lesione anche qui che emerge dal layer posteriore, che va a interrompere la giunzione endometrio-miometriale, in corrispondenza della quale abbiamo l'ingresso a livello endometriale di una serie di vasi multipli a origine multifocale. Quindi questo pattern vascolare è suggestivo di neoplasia. Anche qui, sfruttando i diversi rendering del 3D Power Doppler, possiamo andare a enfatizzare meglio quello che è il pattern vascolare della lesione. Quella che è un po' la mia passione, il tumore della cervice uterina. Vi ricordo che l'esame endocavitario inizia in vagina, quindi la vagina va guardata, la cervice va guardata. L'ecografia ci consente di identificare, descrivere, biopsiare lesioni già al momento della diagnosi, andiamo a stadiare la malattia e, laddove necessario, seguiamo la paziente nel follow-up e possiamo effettuare true cut biopsies in caso di sospetta recidiva. Andiamo a vedere questa lesione. È una lesione ipoecogena, un tumore squamocellulare della cervice uterina che infiltra il compartimento anteriore, infiltra la vescica, e a livello del compartimento laterale abbiamo a sinistra un uretere normale che avete visto, a destra l'uretere è completamente infiltrato e avvolto con una retrodilatazione a monte. Ruotiamo la sonda di 90 gradi e andiamo a valutare quello che è il parametrio. A livello del parametrio laterale, a destra, qui, vi verrà enfatizzata quella che è un'infiltrazione parametriale di grado 4, che definiamo come skip metastasis, altro non sono che linfonodi del parametrio positivi e patologici. Per studiare meglio i fornici, come avete visto invece sulla sinistra, possiamo utilizzare la vaginosonografia, andare a inserire in vagina della soluzione fisiologica per disegnare meglio quello che è il profilo più caudale della lesione, l'interessamento dei fornici e della parete vaginale. Con la sonda convex abbiamo visto che l'uretere era dilatato a livello pelvico, quindi ce lo andiamo a seguire anche in modo retrogrado dal rene alla vescica. Quindi in questo caso vediamo una dilatazione importante della pelvi renale senza ancora atrofia del parenchima, ma riusciamo a seguire tutto il decorso dell'uretere. Qui c'è un linfonodo patologico. Andiamo a seguire l'uretere che scende, che crossa i vasi iliaci e poi si ricongiunge a quello che abbiamo visto prima con la sonda transvaginale. Un modo che a me piace molto per la valutazione dell'infiltrazione parametriale è l'utilizzo dell'ecografia tridimensionale, perché noi andiamo a ricostruire la famosa visualizzazione assiale pura che ottiene il radiologo sulla risonanza, andiamo a navigare all'interno del nostro volume e in una sola visualizzazione possiamo valutare overall a 360 gradi tutti i parametri. Vi faccio vedere un'altra lesione, un tumore più piccolo, anche qui squamocellulare, quindi ipoecogeno, del labbro anteriore ma con una piccola lesione a bacio posteriore. In questo caso il problema della mia collega che aveva giovane, la specializzanda, che aveva iniziato l'ecografia, mi dice: c'è una lesione ovarica. C'è una lesione ovarica, la guardiamo annessiale, la andiamo a guardare, in realtà l'ovaio si vede bene e c'è questa formazione, quindi il nostro problema è una metastasi o è un'altra cosa? Andiamo a studiare prima il nostro tumore, la valutazione dell'infiltrazione parametriale che era assente, ricostruiamo l'albero vascolare della lesione e poi ci dedichiamo alla lesione annessiale che era un'idrosalpinge, quindi non correlata alla lesione. Vi faccio vedere un ultimo tumore della cervice uterina, in questo caso un tumore più difficile perché è un tumore sostanzialmente quasi isoecogeno che cresceva a livello dell'endocervice, del canale cervicale, era un adenocarcinoma della cervice uterina, poi ve lo disegno meglio, un tumore piccolo ma un po' tricky perché è difficile da identificare. Qui vi faccio vedere solo il compartimento anteriore, siamo nel fornice anteriore, andiamo a stimolare lo scorrimento dei piani, escludiamo l'infiltrazione della vescica, ci spostiamo a vedere il parametrio verso il parametrio laterale diviso nelle sue due componenti dal decorso ureterale, qui era tutto libero, il tumore era piccolino all'interno del canale cervicale, questo qui, con la sua vascolarizzazione. Una delle diagnosi più difficili che ci capita di fare nel mio ambulatorio è la diagnosi differenziale della patologia miometriale, perché a fronte di una patologia estremamente diffusa ci vengono comunque selezionate e inviate delle pazienti che hanno degli elementi di atipia e quindi dobbiamo capire se è un fibroma, una variante o qualcosa di peggio. Il qualcosa di peggio è rarissimo, ma non dobbiamo assolutamente perderlo. Ci sono in corso grandi discussioni tra clinici e patologi sulla possibilità di effettuare una diagnostica invasiva al momento della diagnosi, un po' per il rischio di disseminazione, un po' perché la formazione può essere eterogenea e quindi possiamo non essere efficaci con la diagnosi. Vedremo, questo è un campo di ricerca attuale di oggi. E comunque possiamo monitorare le lesioni e biopsiare le sospette recidive. Vi faccio vedere quella che è una formazione francamente maligna per portare a casa quelle che sono le caratteristiche del sarcoma. Questo era un sarcoma indifferenziato, per cui una formazione riccamente vascolarizzata, adicostruttura disomogenea per la presenza di aree cistiche irregolari, era presente una componente necrotica. Se leggete la letter to the editor del gruppo di Leuven che descrive quelli che sono gli step evolutivi della necrosi, questo è un po' lo step finale, quando non abbiamo più la componente centrale iperecogena, ma all'interno la lesione è già colliquata. Questa è la sua ricostruzione tridimensionale con il suo albero vascolare e questo il corrispettivo macroscopico al momento della chirurgia. Vedete che ricalca molto bene quello che era l'aspetto ecografico. A fronte delle lesioni di grandi dimensioni, il fatto di poter avere un ecografo che ci consente un angolo di scansione superiore ai 180 gradi è di fondamentale importanza, perché riusciamo a cogliere nell'interezza una lesione come in questo caso, che si indovava, occupava tutta la pelvi, dimensioni circa 20 centimetri, riusciamo, se vedete, a coglierla completamente e anche nei piani più profondi a non perdere in risoluzione, sia per la valutazione in scala di grigi, sia per quanto riguarda la valutazione con il Doppler, e non è scontato perché di solito riusciamo a vedere bene la vascolarizzazione nei piani superficiali, ma nei piani profondi perdiamo completamente. Nelle lesioni grandi ricordiamoci sempre di andare a valutare la paziente con la sonda anche convex, e questo era il corrispettivo al momento della chirurgia. Un campo di ricerca nostro abbastanza recente, la valutazione del coinvolgimento linfonodale delle neoplasie della vulva. È importante, abbiamo imparato a riconoscere le differenze tra linfonodi reattivi post-reattivi, come quello in alto, in cui abbiamo una vascolarizzazione ilare ben rappresentata, nonostante un ispessimento eccentrico della corticale o un linfonodo negativo, dal linfonodo sotto in cui abbiamo una vascolarizzazione transcapsulare. Come vi dicevo, seguiamo le pazienti nel follow-up e andiamo a identificare con la sonda ecografica potenziali recidive. Questa è una recidiva che abbiamo visto settimana scorsa di un tumore sieroso ovarico di alto grado. Difficile questa modalità di presentazione perché sembra una lesione singola, ma è una lesione adesa alla cupola vaginale e adesa al peritoneo prevescicale. La lesione va a infiltrare completamente l'uretere di sinistra, che vediamo passare e a un certo punto scomparire perché è completamente avvolto a manicotto dalla lesione. E questa è la ricostruzione 3D. Un altro caso di lesione recidiva è questa è una recidiva pelvica di un dermatofibrosarcoma protuberans che la paziente aveva operato 15 anni prima, e anche qui una formazione adesa alla cupola vaginale che con la nostra ricostruzione 3D possiamo andare a studiare molto bene nei rapporti con gli organi adiacenti. L'ultimo caso che vi presento è la real life. Abbiamo ragionato fino adesso a compartimenti stagni. Ho imparato a valutare la massa anesiale, l'endometrio, i linfonodi, ma poi ci arrivano queste pazienti qui. Ci arriva questa paziente inviata per perdite ematiche atipiche algie pelviche che aveva un adenocarcinoma di grado 3 dell'endometrio, un fibroma, la metastasi ovarica e la carcinosi pelvica, goccia di cera del compartimento posteriore, e poi, andando a valutare gli assi vascolari, aveva un linfonodo interiliaco metastatico. Quindi è importante avere le competenze e saperle integrare, perché poi dobbiamo essere in grado di valutare la paziente a 360 gradi. Grazie.
Grazie mille, grazie Valentina. Come sempre per la tua chiarezza e di esposizione, che ormai credo sia apprezzata un po' da tutti, e complimenti per le bellissime immagini. Se avete poi delle domande o qualcosa da chiedere, segnatevele, perché cerchiamo poi alla fine di ricavarci qualche minuto. Adesso presento il professor Alexandros Sortiriadis, che conosco da ben 20 anni, quando eravamo giovani research fellows a Londra, insieme anche a Paolo Cavoretto. Poi ovviamente ognuno prende le sue strade, ed è un piacere adesso vedere che attualmente, dopo insomma molti anni di impegno a livello scientifico, Alex è attualmente professore presso l'Università di Salonicco, come diciamo noi in Italia, Salonicco, e Honorary Secretary dell'ISWOG, nonché Deputy Editor-in-Chief di Ultrasound in Obstetrics and Gynecology, che è la rivista insomma nel nostro ambito più diffusa. E no, ma ha detto di non dirlo.
I will take over this September.
No. E il professor Sortiriadis ci parlerà delle linee guida sull'ecografia del terzo trimestre. Please, Alex.
So thank you so much, Nicola. Thank you for having me here. I'm extremely happy to be among so many friends and my teacher, Professor Nikolaidis, with whom I started everything. So fortunately enough, we don't have an oncologic patient this time. We have a pregnant woman who has reached uneventfully the third trimester, and we are talking about the rationale of offering a third trimester scan. Third trimester scan has been previously rather neglected. It was only used to assess the growth of the fetus because it would not improve hard outcomes, and we will see what we're talking about. However, the studies that have shown that are really outdated. Today, the scan is so advanced and so many things have been added to the third trimester scan, so that now it is implemented as a routine in many countries, including Italy, France, Greece, and many other countries. And that's actually a review from the team of my friend Paolo Cavoretto, which shows the guidelines, international guidelines. We see that there are actually only few guidelines. Most of them agree that third trimester scan should be offered to all women during the third trimester. ISWOG is taking a more conservative position, and it says that as yet there is no convincing evidence that routine ultrasound in low-risk third trimester women would improve perinatal or maternal outcome. Now, that's really conservative. That's probably the main criticism that has been done for this guideline, and we will talk about that in the next slide. And the reason why some guidelines are really conservative and do not recommend that the third trimester scan should be offered to all women is these studies. So these studies have found their way in a coherent meta-analysis, and if we see their components, we will see that what they describe as the third trimester scan is not what we're doing today. So these scans had failed to show any improvement in the rare outcomes, like, for example, perinatal death, but they have not incorporated the benefits from late anatomical diagnosis. So it's an incomplete information which does not do a favor to what is today a third trimester scan. So what is today a third trimester scan? Well, there are certain components. We check the placental localization, and I remember from the time I was a research fellow, Professor Nikolaidis used to say that first you check where the placenta is, and then you check the rest of the baby, because if you are missing a placenta previa, that can kill the mother. So we check the placental localization, we check the fetal presentation. When you have a term breech pregnancy and you don't know it, you may increase perinatal morbidity or even mortality. Of course, we check the fetal size and growth. We check the fetal anatomy, and that's a huge advancement. and we also check the amniotic fluid. If we have concerns about placental localization, then we very easily do a transvaginal scan, and we also look for placental abnormal invasion and also vasa previa. If we have concerns about the fetal size, then we proceed to Doppler studies. Placental localization should be offered to all women who do a third trimester scan. But it's particularly important in the case of a previously detected placenta previa. And if this placenta previa is major or is located on the site of a previous cesarean scar, then this scan should be made at 28 weeks. If the placenta is minor previa, then we can do it slightly later. If we have a posterior placenta, then at the third trimester, it can be very difficult to assess exactly where it ends, and therefore we should have a very low threshold to proceed to a transvaginal scan. And of course, whenever we have a placenta previa plus a prior cesarean section or uterine surgery, and that's a thing we tend to forget. It's not only a previous cesarean section, it's also surgery and especially laparoscopic myomectomy. Then we have to proceed to a detailed ultrasound to rule out a morbidly adherent placenta. We know the signs, the ultrasound signs. We know the loss of the retroplacental clear zone. We know myometrial thinning. We know these placental bulges and exophytic masses, but probably the most common thing and the easiest thing to spot is these so-called lacunae in the placenta. Also, the bridging vessels are supposed to be, because of local hyperemia, they're not supposed to be real bridges, but they are quite spectacular. However, regardless from the presence of ultrasound findings, whenever we have a placenta previa and a previous cesarean section or a previous uterine surgery, we still should consider this woman as high risk, and we should manage her in centers experienced in the surgical management of abnormally invasive placenta. And then, of course, there is MRI. MRI can be used and can be useful in specific cases. We can use it when we have a risk for placenta, for abnormally adherent placenta in uncommon locations, like, for example, a posterior placenta, when the placenta is located at the site of a prior myomectomy, when we have inconclusive ultrasound findings, or, in contrary, when we have ultrasound findings suggesting of severe placenta accreta spectrum. In this case, we need to see whether the parametria are also involved. And the reason behind looking for vasa previa, and another fellow of us, Ranjit Akolekar, has done a fantastic job on that. So the rationale behind looking for vasa previa is because prenatal knowledge of vasa previa greatly improves the prognosis. If we don't know prenatally that a woman has vasa previa, there is a 55% chance of perinatal loss. This chance goes down practically to zero if we have a prenatal diagnosis. And we have to be especially vigilant in two cases. First, when vasa previa were previously identified in the second trimester scan, fortunately enough, in these cases, there is a 25% chance that they resolve up to the third trimester. And second, when we have risk factors for vasa previa. And these risk factors, we have to be very vigilant for them. They are placenta previa, second trimester low-lying placenta, bilobed placenta, or placenta with succensuate lobes, and also multiple gestation. Why is it important to be vigilant of risk factors? Because 80% of the cases of vasa previa have at least one risk factor. And then, of course, there is fetal size and growth, and here we have to make a distinction. Size is a snapshot, how big the baby is. Growth is how size evolves during time. So growth requires more measurements, and we have to be careful, and we have to remember that we have to leave at least 2 weeks interval between serial assessments. And this happens because ultrasound has variability. You can check that in more detail. That's a QR code to the SIEOG growth guideline. It's going to be updated anytime soon. Conventionally, a normal size is defined as fetal weight or abdominal circumference between the 10th and the 90th centile. Small is conventionally defined as fetal as estimated weight or abdominal circumference below the 10th centile, but not all small fetuses are FGR. If we talk about fetal growth restriction, so that's a subcategory of the small fetuses, the fetus has to be either too small, so below the third centile, or just small between the third and the 10th centile with additional signs, Doppler signs of placental insufficiency or fetal hypoxia. And of course, all these distinctions are simplistic. I mean, fetal growth restriction as well as preeclampsia is a spectrum disease, so you cannot draw these boundaries in a very concrete fashion. But, you know, again, they're useful just as a starting point. Large, at the other side, is defined as a fetus which is above the 90th centile, and macrosomia, and this is a distinction between LG and macrosomia. Macrosomia uses an absolute cutoff, usually 4 or 4.5 kilos at term. And of course, multiple research, much of that has been performed by the Fetal Medicine Foundation, has found that if you want to detect growth anomalies, either a small fetus or a large fetus, you have to do the scan as close to 36 weeks as possible. So when we screen for growth anomalies, we prefer 36 rather than 32 weeks. And I'll come back to that a bit later. But how about the anatomy? The expansion of the third trimester scan to the anatomy is quite important. Why? Because, again, a large body of evidence, mainly by the Fetal Medicine Foundation, has shown that specific anomalies tend to be diagnosed mostly or even exclusively in the third trimester. And that's quite an important message. And of course, in practical terms, you cannot examine the whole fetus at the third trimester, and you probably don't need to examine the whole fetus in the third trimester because not all organs evolve. I mean, if you have a cleft lip, you have it from the very beginning. But there are certain organs and systems that evolve during pregnancy, and evolve means that they can change. And that's a snapshot of the SIEOG guideline, which provides a structured approach to the examination of the anatomy in the third trimester. Very briefly, regarding the head, we'll look at the size and the shape of the head, and we have to remember that microcephaly is not just a small head. Microcephaly is a very small head, a head that is below below 2 standard deviation, and especially below 3 standard deviation below the expected mean for the gestational age. We know that the shape of the head is a smooth oval. You can have a mild dolichocephaly in cases of bridge or transfer presentations. However, a more malformed shape of the head should raise the suspicion for abnormal conditions like craniosynostosis. Well, the brain, I'm not going to talk about the brain because we have Professor Aretsfo with us, but I will just remind you that about half of the cases of ventriculomegaly develop during the third trimester. The majority of fetal tumors, in line with other fetal tumors, are being picked up in the third trimester, and vascular incidents like intraventricular hemorrhage can happen anywhere in pregnancy. So we have to be to have that in mind. The heart is also an organ that changes during pregnancy, and can we click on the upper video, please? And a very easy way for someone who's not specialist, yeah, great, to check the heart, a very simple way is to start from the section of the abdomen and then move upwards without changing anything. So start from the abdomen, you see the 4 chambers view, you come a bit more upwards, you see the 3 vessels trachea view, and in this way, you can know about the position, the site, and the symmetry of the heart. And we know that because the right heart during the fetal life produces more work, at the end of the pregnancy, the structures of the right heart become slightly bigger than the structures of the left heart. However, a severe asymmetry is always abnormal, and it should prompt a specialized fetal echo. We have to check for pericardial fluid. A small amount of pericardial fluid is normal, but an amount more than 2 millimeters can be suspicious. And also we have to check for tumors. Can we click on the video, please? The most common heart tumor, no, the second video, below tumors. Oh, I have a mouse, great. So fetal, I cannot see the mouse. Nope. I cannot see the arrow. Okay, great. So cardiac tumors as well as other tumors of the fetus, as I said before, can very often develop in the third trimester or be diagnosed in the third trimester, and the most common ones are rhabdomyoma and myxomas. The prenatal detection of rhabdomyoma is quite essential because it is quite often associated with tuberous sclerosis. We proceed to the diaphragm. We take parasagittal views. 20% of congenital diaphragmatic hernia are diagnosed in the third trimester. Quite important because they both prompt to additional tests and they also change perinatal care. Kidneys, we look for calcifications. Abdomen, we look for calcifications. We look for collections like the ascites you see there and cysts. In a female fetus, the most common cyst in the third trimester is an ovarian cyst as a result of the response of the developing ovary to the circulating hormones. We look for bowel dilatation. We know that the cutoff for the intestinal lumen in the third trimester is 10 millimeters. However, in practical terms, the risk for complications increases steeply when the lumen is more than 14 millimeters. We check the kidneys. Again, the study from the Fetal Medicine Foundation has shown that 2/3 of hydronephrosis develop in the third trimester. So we have to be very careful about that because hydronephrosis is not a big anomaly by itself, but it is often associated with urinary tract infections after birth, which, if left unattended, can cause permanent damage, permanent harm to the kidney. So that's how detection of a small anomaly can change the prognosis. So the limit for the anteroposterior pelvic diameter in the third trimester is 7 millimeters, but the risk for the need for surgical intervention increases a lot when you have a dilatation of at least 15 millimeters, especially when the calyces are also dilated. And now I get you back to the previous question, when should third trimester scan be performed? If our main objective is to screen for abnormalities of growth, then it should be close to 36 weeks. But if our main objectives is to look again, to check again the anatomy of the fetus, then earlier may be better. Why? For two reasons. Because later imaging becomes more problematic because the fetal is flexed and prone, because the amniotic fluid volume is relatively low in comparison to the size of the fetus, and because especially the cranial bones are becoming thicker. So for a non-specialist, visualization of the brain may become a bit more challenging. The second reason is that if we detect something in the third trimester, something, an anatomical abnormality, then we may need to have extra tests. And I don't care about MRI, this can be done fast, but especially prenatal exome sequencing today, in some environments, can take up to 3 or 4 weeks, so you have to have time. So SIEOG takes a more liberal position, and it says that depending on what is your objective, you can do the scan between 32 and 36 weeks. Again, that's the review by the group of Paolo, and most of the societies do not take a certain stance, but the Italian society prioritizes 34 to 36 weeks. And then, in the end, we have to look, also we have to check the amniotic fluid. If we want to be precise about the quantity of the amniotic fluid, we have to do the dye dilution technique. However, this is neither practical nor necessary. So we are using semi-quantitative proxies, 2 of them, amniotic fluid index and deepest pool. Both of them are similarly inaccurate. Both of them are just proxies. However, there has been research that shows that if we want to reduce the rate of false positive results, so if we want to reduce the rate of unneeded interventions, we may prefer AFI when polyhydramnios is suspected, and we may prefer the deepest pool when oligohydramnios is suspected. And I will highlight some points about polyhydramnios, because polyhydramnios is generally more worrisome. So we know that polyhydramnios can be the result of either increased amniotic fluid production or reduced amniotic fluid resorption, so the scan should be targeted and examinations in general should be targeted for those two cases. And if nothing is found, then we can talk about idiopathic polyhydramnios. However, we know today that even in cases of apparently isolated polyhydramnios, there is a risk of 3 to 6% for either chromosomal or monogenic disease, especially in the context of a small fetus with polyhydramnios, especially in the context of an early onset severe polyhydramnios. And there is another very specific case, the case of polyhydramnios with reduced movements. And in this case, there is also a risk of myotonic dystrophy, which is produced, which is caused by another genetic mechanism. So prenatal exome sequencing does not detect it, and we have to ask for extra tests. Of course, the guidelines are not addressing all the questions. They don't tell us what is happening, what should we look for, what should we prioritize when a fetus first presents during the third trimester. And again, another thing that has to be changed, in my opinion, is the recommendation for universal scan. The third trimester scan should be offered to all women, regardless of the prior risk, because the benefit from late anatomical diagnosis has not been yet sufficiently acknowledged. Thank you very much.
Thank you. Thank you, Alex. Please have a seat. We will hopefully discuss something later. Thank you for this very comprehensive presentation on third trimester scan. It's very nice to see that most of the recommendations and of guidelines from SIEOG are basically fed by the huge body of evidence produced by the Fetal Medicine Foundation. And that is the proof that at some point, high-quality research may change the system, also thanks to you guys that take forward this type of philosophy.
High-quality research will eventually find its way into guidelines. Probably with some delay, but it will find its way.
Thank you. Adesso andiamo avanti. Come direbbe il professor Nicolaides in uno dei suoi congressi verso le 9, le 10 di sera, we are perfectly on time. Introduco Anastasia Arekvo, che è professoressa al King's College Hospital and University di Londra, lavora nel gruppo del professor Nicolaides, dove svolge ormai da anni un intenso lavoro dal punto di vista scientifico e dal punto di vista educazionale, con l'organizzazione di molti corsi di formazione, e ci parlerà dell'approccio sistematico con cui fondamentalmente dovrebbe essere eseguita la neurosonografia. Neurosonography made systematic, plane by plane. Diamo qualche secondo per sistemare. Eccoci qua.
Thank you very much. Thank you very much once again to the organizing committee for the invitation, Nicola for the introduction, and of course GE for organizing this lunch symposium. So now we'll change topic again completely, and we will move towards the fetal brain only, and we will discuss more mid-gestation assessment of the fetal brain. However, all the planes and everything that I will show you is equally applicable for the third trimester as well. So whenever you have a baby at third trimester, whether it's 32 or 36 weeks of gestation, try and acquire all the planes to assess fetal brain in as many details as possible. So why do we talk about fetal brain in general? Because we know that it will affect about 1% of all pregnancies at birth. Of course, big proportion of severe brain abnormalities will result in termination of pregnancy earlier, and perhaps some severe malformations may result in stillbirth as well. In Italy, we have, I had to Google, it's about 3,000 hundreds of live births every year. So we estimate that about 3,000 babies will be born with brain abnormality. And what are these, the most common brain abnormalities? These are neural tube defects, such as spina bifida or encephalocele, ventriculomegaly from mild to severe, callosal pathology, agenesis, partial agenesis, dysgenesis, posterior fossa abnormalities, microcephaly, macrocephaly, and cortical malformations. Now, when it comes to the cortical malformations, we know that we're not great in detecting cortical malformations routinely. However, with introduction of systematic neurosonography, I believe that we can improve detection rate of these malformations as well. Now let's talk about the planes, and these are the standard planes that you are all familiar with, and I will try to do it a little bit more systematic for your clinical practice. So first of all, transventricular plane. We all know that we have to assess the shape and the size of the fetal head. We do assess the midline, that it should be straight throughout the pregnancy. We do assess cavum septi pellucidity, again, shape and the size. We look at the lateral ventricles, and here I want to point that there are multiple ventricles. There are two, and we don't assess only the distal one, but I will show you how to assess the proximal one as well. And of course, parieto-occipital fissure that should be visualized from 20 weeks of gestation onwards. Then we move to the transthalamic plane, and this is where we assess the presence and anatomical appearance of the thalami, third ventricle, and the sylvian fissure. And then we move to the transcerebellar plane, and this is where we assess size, shape of cerebellum and the vermis, fourth ventricle, and cisterna magna. And these are the classical standard planes. And the question is there anything else we can do systematically, routinely, by performing a screening ultrasound examination to improve detection of brain abnormality? And the answer is definitely yes. And these are sagittal planes. So by visualizing through the anterior fontanelle, we visualize corpus callosum. And here, transabdominally, you can assess the presence of corpus callosum. You can, if you want, even measure, even though it's an ongoing big debate whether corpus callosum should be measured or not. However, if you see it and the integrity of the corpus callosum is intact and it looks healthy, you should be satisfied with this picture. And then through the posterior fontanelle, again, you can visualize clearly corpus callosum, but also vermis and the brainstem. And these are very easy manipulation with your probe and the fetal head transabdominally. Can we do more than that? And again, the answer is definitely yes. And these are coronal planes. By visualizing coronal planes, we assess the midline. Again, it should be straight throughout the pregnancy. We'll look at the corpus callosum from the coronal plane as well. We'll look at the anterior complex on the ganglionic eminence, which is very important to confirm, especially at 20 weeks of gestation, the anatomical appearance of it. And we'll look also on the basal ganglia. Again, transabdominally, it can be achieved. Then we move to the plane of at the level of thalami, again, third ventricle and sylvian fissure. And then we move to the lateral ventricles and cerebellum. Now, this QR code, unfortunately, is not working. But after this lunch symposium, you can go to the GE representative and ask for the QR code that is functioning, and perhaps you will have access to the poster that will take you in more details how to achieve all these standard planes and the visualization of the structures that should be achieved during the scan. And then, of course, if you are used to do transvaginal neurosonography, and I would encourage every practitioner to do and practice transvaginal neurosonography, because by doing very simple examination, you can see so much more, especially if you do cervical assessment at 20 weeks, and baby is in cephalic presentation. It requires so little for you to assess the brain and see the whole anatomical picture. So here, I hope it will play. Yes. So this is the fetus at 32 weeks, and these are the anatomical landmarks that are important to visualize. Here we have a sylvian fissure, thalami, third ventricle in between, cerebellum, vermis, calcarine sulci, third ventricle again, and then we move to the front of the head, and it's very important to confirm olfactory sulci as well, that they are present, interhemispheric fissure, and then you slowly move to the sagittal plane, and you clearly visualize the whole anatomy of the fetal brain, hopefully confirming normality, vermis, corpus callosum. You look at the lamination, and which is achieved in the parasagittal view. You look at the caudothalamic groove, again, very important anatomical landmark to confirm normality. Then the third ventricle, and then you move back to the coronal planes. And within 2 minutes, not more than that, if you are used to perform transvaginal neurosonography, you will confirm, in the majority of the cases, you will confirm normal appearance of the brain. Now, if you start practicing neurosonography transvaginally, it is very important, of course, to recognize that the brain is changing throughout the pregnancy significantly. And if you used to do a transvaginal scan at 20 weeks, you don't expect the same picture at 32 weeks or 35 weeks because the brain is changing, especially cortical development is changing. So I would advise you to have an atlas in front of you, week by week, representing normal appearance of the cortical anatomy. And then, of course, if we go back to the transvaginal approach, we are used to assess the skull, and I will take you through the assessment of the skull in more a little bit systematic way. So transabdominal approach, we look, of course, on and confirm normal shape of the fetal skull, and we exclude lemon, strawberry, or clover leaf shape heads because we know that the lemon shape is strongly associated with spina bifida, strawberry shape is associated with trisomy 18, and clover leaf is sign of craniosynostosis. Then, of course, we rule out conditions such as acrania and encephalocele. We confirm the normality of the size of the fetal head, normal ossification. Now, there is no parameter as such to confirm normality of ossification, but if you assess brain transabdominally and you cannot clearly see the proximal part of the brain, you should be reassured that the ossification is normal, because if you see proximal part of the brain too clearly, you may suspect that the bones are poorly ossified. And of course, we look at the sutures of the skull. We confirm that they are all open. And conditions such as acrania, we know that they should be detected at 12 weeks, 11, 12 weeks when we perform routine first trimester scan. Unfortunately, there are cases that this abnormality is detected much later. As in the second picture, it's a picture of 22-weeker presenting with anencephaly in the late gestation. Conditions such as encephalocele should be, again, in majority of the cases, should be detected in the first trimester, but we know that it's easier to detect in the second trimester because the consequence of encephalocele becomes more apparent in the late gestation. And whenever you have one clear encephalocele, assess the skull, the integrity of the skull in more details because you may find more than one encephalocele. Then, as I said, we assess the size of the head, and we have to make sure that we don't miss cases of microcephaly. And as Sotriades said, that true microcephaly is less than 3 standard deviations below the mean. And why we are worried about microcephaly? Because we know that developmental risk, developmental delay is significant if the head is below 3 standard deviations or less. And what are the most common causes of microcephaly? This can be as simple as infection. And 21-weeker can present with severe microcephaly already in this gestation. And of course, in this case, you will have a truly small head below 3 standard deviation. And of course, in cases of severe congenital infection, you will have more signs of this pathology. For example, mild ventriculomegaly, hyperechogenic borders of the lateral ventricles, and abnormally developing cortex, which, as in this case, you can clearly suspect from the abdominal approach. And if you move to transvaginal approach, you will confirm abnormally developing cortex, you will see multiple calcifications, and periventricular hyperechogenicity. And in this case, CMV infection was confirmed. In contrary, if we move to the macrocephaly, it is also important to identify babies with enlarged size of the head, defined as 2 or more standard deviations above the mean. And it is important to remember that majority of the large heads will be familial without any underlying pathology, and the prognosis will be good. And in this case, you have to remember to look at the heads of the parents, and if father's head is truly large, then you don't have to worry too much. Most likely, this will be familial. But what are the other causes of large head? This can be as simple as severe ventriculomegaly, whether it's genetic mutation caused ventriculomegaly or is obstructive ventriculomegaly. This will increase size of the head. Tumor can also increase volume of the brain and therefore increase the size of the head. Vein of Galen malformations can also increase size of the head, but of course in this case you will see severely affected brain with the abnormal vasculature of the brain. But there will be also cases of, for example, Noonan syndrome that will present with enlarged size of the head, and only if you perform transvaginal neurosonography or MRI, you will detect abnormally developing cortex as well, and if you carry on with genetic evaluation, you will confirm abnormality. Hemimegalencephaly, again detectable with help of transvaginal approach or MRI, can be, the fetus will present with large head, and only if you look for more details how the brain is developing, you will detect these abnormalities. And polymicrogyria, similar approach, genetically abnormal developing brain due to genetic mutation. Fetus will present with a large head, and by doing a systematic approach, you will detect the cause of this large head. Now let's move to the anterior complex. We are all used to, and we are familiar, of course, with the approach of assessing cavum septipellucidity. And we all know that normal presentation of cavum septipellucidity is indirect sign of normally developing corpus callosum. And we know that shape of anterior complex can slightly vary, and you can see the normal appearance of the anterior complex. It can be more rectangular, more triangular, a little bit wider, a little bit more narrow. All of these are normal variants of anterior complex. It should be visible from 18 weeks up to 36 weeks of gestation, and we know that in the late gestation, the cavum obliterates the fluid within cavum disappears, and the septi obliterates. So it's quite normal not to see cavum in the third trimester. And the width of the cavum should be less than 10 millimeters. And again, if the cavum is too prominent, you don't have to measure in every case, but if you see that it's too prominent or it's wider than longer, you may suspect underlying pathology of corpus callosum. And cavum verge is not an abnormality, it's normal variant of cavum septipellucidity. Now, if the cavum is abnormal, why are we worried about this sign? Because we know that abnormal cavum septipellucidity can be associated with abnormally developing corpus callosum, can be a sign of holoprosencephaly, or severe ventriculomegaly, because in case of severe ventriculomegaly, the pressure, intracranial pressure, may just destroy the septi, and you may not see cavum septipellucidity at all, but of course you will see severe ventriculomegaly. In case of porencephaly or destructive processes such as severe infection, it will also affect how the cavum appears, and you may have very abnormal presentation. And in case of posterior fossa anomalies, which most likely will be genetically caused abnormalities of the brain, you will have abnormal posterior fossa and abnormal appearance of the cavum septipellucidity. Now, when it comes to the anomalies of corpus callosum, and this can be a separate topic for many hours, but why are we worried about the corpus callosum and especially about the abnormal cavum septipellucidity? Because as long as the cavum is normal, you may rely on this sign that corpus callosum is also normal. However, I would like everyone to, in the beginning of my lecture, to get a sagittal plane routinely and assess corpus callosum, because I believe with advances in ultrasound and with advances in education of ultrasound, it's not enough to rely on indirect sign of corpus callosum. Because we will miss cases of complete agenesis, partial agenesis, and this genetic corpus callosum. And we know that partial agenesis of corpus callosum or dysgenesis of corpus callosum is strongly associated with underlying chromosomal or genetic conditions, and it is important to identify these cases in a timely manner. Now let's move to the ventricular system. Again, nothing new. You all look at the lateral ventricle. You know that you have to measure lateral ventricle at the level of parieto-occipital fissure, and the size of the lateral ventricle should be 10 or less millimeters to confirm the normality. However, it is also very important to look not on the size of the lateral ventricle, but to assess the shape, to look at the choroid plexus, ventricular wall, and periventricular area, because any abnormality around the ventricle can also be a sign of underlying pathology. And remember that ventriculomegaly is a strong marker of underlying cranial or extracranial anomaly. Remember, I told you that it is not enough to look at the distal ventricle only. Try and achieve the perfect view of the proximal ventricle as well. And the best way to visualize proximal ventricle is through the lambdoid suture. And it is very important to keep the symmetry of hemispheres equal. Because if you tilt the probe too much and you see only the proximal hemisphere, of course, if you measure the ventricle in this plane, you will overestimate a ventricle and you will alarm the family and do unnecessary evaluation to understand the cause of ventriculomegaly. But if you keep hemispheres equal and you look at the ventricle through the lambdoid suture and you are happy with the appearance of it, it's more than enough. You don't have to measure proximal ventricle as well. And when we come to the ventriculomegaly, true ventriculomegaly, it is important to perform certain steps to understand the cause of ventriculomegaly. And it can be due to obstructive process, for example, aqueductal stenosis, Chiari malformation, or intraventricular hemorrhage, any process that will obstruct normal circulation of the cerebrospinal fluid within the brain. It can be due to destructive processes, for example, congenital infection, porencephaly, or ischemic injury, when parenchyma is being destroyed due to one or another reason, and the fluid is just simply taking over the volume of the brain. Ventriculomegaly can also be due to developmental problems in case of congenital, in case of chromosomal abnormalities or genetic mutations. Again, brain will develop in abnormal fashion, and ventriculomegaly will just take, the fluid will take over healthy parenchyma. And hypersecretion, which is much more rare cause of ventriculomegaly because choroid plexus papilloma is rare condition. However, to achieve the conclusive diagnosis and to understand the cause of ventriculomegaly, we have to perform a detailed anatomy, and it's not only the brain, but entire fetal anatomy, because if you have ventriculomegaly and additional abnormalities in the heart, kidneys, extremities, of course, this will become much more complicated case. Neurosonography or MRI, if you cannot perform neurosonography due to one or another reason, MRI will be your tool to assess fetal brain in more details. Of course, not to forget to perform torch screening, because common is common, and CMV infection, for example, will cause brain damage, and ventriculomegaly can be one of the signs, and of course, genetic evaluation. Now, let's move to the posterior fossa. When we do assess posterior fossa, we look at the cerebellum, vermis, fourth ventricle, and cisterna magna. And we quite often receive a referral with a abnormal appearance. Oh, I'm looking for my mouse. If I can play the video. I cannot.
Yeah, perché il mouse è attaccato al... Sì, perché il mouse è attaccato al suo, E appunto...
It's okay.
No, il mouse is not on your personal computer. This mouse...
It's okay, don't worry. So I wanted to show you the dural folds. Dural folds, which is anatomical normal variation, and not... no, I cannot show you, but dural folds is not abnormality. So it's a septation in the posterior fossa, and it's normal finding if you have normal anatomical biometry of the cerebellum, and you see the vermis clearly at any gestation, then dural folds is not an abnormality, so don't panic if you see them. Now, of course, you will have cases with open fourth ventricle, as in this case. You will see that the vermis is not visualized in the standard plane. And this can be absolutely normal finding up to 18 weeks of gestation. However, if you see baby after 20 weeks and you have this open fourth ventricle, you have to be very careful before you say that this is completely normal. You have to confirm normal anatomy of the vermis and preferably biometry as well to confirm that this is just simply vermion malrotation and not vermion abnormality. Because, as I said, in many cases, this will be a normal variant, especially if this is just a Blake's pouch cyst. And yesterday we had a beautiful presentation on abnormalities of posterior fossa. But we may also detect cases with vermion hypoplasia, where you have this open fourth ventricle after 20 weeks, but if you look at the vermis and you try to assess the anatomy of it, or even if you perform a biometry of the vermis, you will see very abnormal vermion presentation. And of course, cases of Dandy-Walker malformation are easy to miss, because in case of Dandy-Walker malformation, you will have so many other abnormalities, including brain, but also extracranial anatomy. When it comes to the vermion biometry, it doesn't really matter how you measure vermis. The most important is to, if you compare your measurement with the reference range, make sure that the reference range, that the way the measurement is achieved is the same with how you achieve the measurement. Because some references will measure only anterior-posterior diameter, some references will measure the volume of the vermis, and you have to make sure that the measurement that you are obtaining is the same as you compare to the reference range. When it comes to the fourth ventricle, it is also a very important landmark to confirm the normality of posterior fossa, especially if you perform transabdominal scan only, because fourth ventricle should have a triangular shape and should be wider than longer. And you will see the cases with abnormal fourth ventricle. For example, in case of Joubert syndrome, the fourth ventricle will be very narrow. In case of rhomboencephalosynapsis, there will be no fourth ventricle at all, because there is no vermis and the cerebellar hemispheres are fused along the midline, so there is no fourth ventricle. And in the malformation of cortical development, you may have very abnormal presentation of fourth ventricle being very irregular. Few words about the cortex, and then I finish. Cortex is very important landmark, again, to confirm the normality of brain development. And we are all familiar with the picture of the midline and sylvian fissure that should be visualized from 20 weeks of gestation, and of course, parieto-occipital fissure, again, that should be seen after 20 weeks of gestation. If you move to the coronal plane, you can see clearly sylvian fissure from 19, 20 weeks of gestation, and as I told you before, throughout the pregnancy, it will change the appearance and the shape. Olfactory sulci and calcarine sulci, also very important to confirm the normality. They should be visible after 22 weeks, and if you don't see them by 26 weeks, it is an alarming marker, because they should be there. So if you don't see this sulci after 26 weeks, you have to look for more abnormalities. And there are several references and the ways how you can assess sulcation and maturation of the sylvian fissure. It can be done through the abdominal approach. There are references and clearly defined references how the sylvian fissure should appear week by week. Ritsuko Pu from Japan introduced more objective assessment of the sylvian fissure by measuring specific angles to confirm the normally developing sylvian fissure. And there are also different approaches with advances in 3D ultrasound. We can now assess, again, cortical maturation without transvaginal approach. This is it, and I just want to invite you to visit the Fetal Medicine Foundation website, where you can find a more descriptive way how to assess brain of the fetus transabdominally, transvaginally, and also it's a big library of abnormalities that can be very useful in the clinical practice. Thank you very much.
Thank you very much, Anastasia, for this brilliant overview on the fetal brain A to Z. Unfortunately, they told me with a very threatening sort of signals that we cannot do any discussion, so Thank you, everybody. Thanks to the speakers. It was a very interesting meeting in terms of scientific content, and the number of people that are still here are the proof for that. So thank you very much, and thanks to GE.